Health ministries worldwide are taking medications once considered routine neurological treatments, drugs like gabapentin, pregabalin, and baclofen, and locking them into highly surveilled tracking grids. In April 2019, the UK government legally reclassified gabapentin and pregabalin as Schedule III controlled drugs, adding new requirements to how they are handled at the retail pharmacy level. Shortly after, the Russian Ministry of Health mirrored this crackdown, issuing a July 1st mandate that forced baclofen and gabapentin into their strict subject quantitative accounting system, known as PKU. These interventions are unusual because these are not traditional narcotics. They are essential non-opioid therapeutics prescribed for multiple sclerosis spasticity, trigeminal neuralgia, and epilepsy. The clinical profile of these medications has not changed. Instead, this international restriction is a response to a systemic failure at the retail distribution level. To understand why the retail system broke down, we have to look at the pharmacology. Drugs like gabapentin act as GABA analogs, while baclofen activates GABA B receptors in the brain to depress the central nervous system and relax muscle spasticity. On the black market, these chemical pathways are exploited to mitigate severe alcohol withdrawal or to chemically potentiate the highs of opioids. Because they do not trigger the same red flags as classic narcotics, bulk prescriptions for these drugs often bypass traditional monitoring systems, appearing as ordinary maintenance medications. These drugs occupy a volatile space between essential neurology and powerful intoxicants. When a therapeutic assumes a dual-use profile, standard clinical gatekeeping protocols often prove insufficient to prevent diversion. We have specific data on why these retail failures occur. A 2020 study by Porseva and colleagues surveyed 396 pharmaceutical specialists to analyze retail dispensing behavior for these exact medications. This chart shows intentional clinical violations. When asked if they dispense these drugs knowing the patient intended abuse, 82.8% of surveyed pharmacists answered yes. 80.1% cited increasing revenue as their primary motivation. Additionally, 50% admitted lacking specific information on the drug's abuse profiles. This manifests operationally as an inability to follow protocols. Many retail staff could not distinguish between standard Form 107-1 prescriptions and the legally mandated, highly restricted Form 148-1 protocols required for monitored substances. When retail motivations and clinical ethics conflict in this way, the resulting data suggests that professional discretion alone creates a significant point of failure. Consequently, state health ministries are moving to remove that discretion from the process. Health ministries are responding to this data by stripping dispensing autonomy away from the retail counter. In the UK, this means doctors are now legally restricted to a maximum 30-day supply on a single prescription, and electronic repeat prescriptions for these drugs have been revoked or severely limited. At the point of sale, patients face physical friction. They must show proof of identity, pick up their medicine quickly, and respect a 28-day window. This prevents dangerous stockpiling. The Russian PKU framework creates a closed-loop electronic audit trail. Every transaction is tracked from the physician to mandatory clearance in the state labeling system. A rogue cashier cannot bypass it. Pharmacies must also retain physical prescriptions in secure storage for 3 years. Severe administrative and criminal liabilities now apply to those who bypass these systems. This includes penalties for unauthorized internet courier transport and incoming legislation targeting the sale of veterinary analogs, known as zoonarcotics. To counteract the revenue motive at the retail counter, governments are replacing human discretion with hard-coded quantitative barriers. Historically, the healthcare system relied on the pharmacist as a trusted community gatekeeper. In that model, professional discretion was considered enough to ensure patient safety. Modern data reveals that this model is no longer sufficient. High-margin therapeutics and corporate revenue quotas have created pressures that professional ethics alone struggle to balance. In this environment, a drug's safety profile is defined just as much by the security of its distribution network as it is by its chemical pharmacology. For administrators and compliance officers, the management of dual-use neurology drugs has shifted from standard retail inventory into a distinct logistical category, one where operational viability depends on the precision of state-level auditing and tracking.